So good evening and a warm welcome to all the viewers joining us. I am Avinash Singh and on behalf of RPG Life Sciences, I welcome all for today's exciting webinar on resistant hypertension and use of diuretics, a subject which needs to be focused more especially in this age of its wide prevalence. To enlighten upon same, it's my pleasure to introduce our speaker for tonight, a renowned and a respected cardiothoracic and vascular surgeon of Guwahati, Dr. Bikash Rai Das. Welcome, Das sir, and pleasure
Yeah,
having you here today with us. Dr. Bikash is an experienced cardiologist with expertise of 17 years in this field. He has completed his MBBS and MS from Assam Medical College, later completed his DNB cardiothoracic and vascular surgery, and then pursued MNAMS CTVS from National Academy of Medical Sciences. He also holds an MBA degree. Moreover, he is an esteemed member of Indian Medical Association and Indian Association of Cardiothoracic and Thoracic Region Surgeons. Currently, Dr. Bikash is associated as a senior consultant cardiothoracic and vascular surgeon in Health City Hospital, Guwahati. It would be very great experience to listen more on such an exciting topic. And for that, without any further ado, I welcome Dr. Das and would request him to please carry forward the session. Thank you, sir. Over to you.
yeah. First of all, thank you very much for giving me this opportunity to interact with all the doctors. This is a very difficult time and we all are worried and we have to be very cautious and all. So that is the only way to get rid of this disease and get yourself prevented from getting this COVID virus. So stay indoors as much as possible, and if there is nothing, don't go out and all. And maybe you can utilize your time in studying up the latest advances in the medical sciences. So today, in that context, we are trying to discuss a very relevant topic, and almost all of us might have got some patients who are suffering from resistant hypertension. So how do you diagnose a patient of resistant hypertension, and how do you approach that patient with your treatment? So that's what we'll be discussing today, and let us go into the details. So you see, blood pressure is very, very common, and even a mosquito knows that, like, the blood pressure patients are at risk of developing a heart disease, at risk of developing kidney failure, at risk of developing a stroke, or at risk developing a peripheral vascular disease. Like in this cartoon, the mosquito is telling the other mosquito that I told you he had high blood pressure. So you are not supposed to suck the blood of a patient with high blood pressure. So even the mosquito knows the dangers of hypertension. Now, resistant hypertension, it has got various causes, various risk factors, and some of the risk factors I have depicted in this picture. It may be because of endothelial dysfunction, elevated levels of aldosterone, excess volume, sympathetic overstimulus, genetic factors, insulin resistance. All these things can lead to resistant hypertension. And if you look at the definition of resistant hypertension, then it is defined as a blood pressure that remains above goal. So nowadays the goal is 130 by 80. So you have to bring down the blood pressure below 130 by 80. So that is what the American Heart Association says nowadays. Even Indian Society of Hypertension also agrees to that. So if not 130/80, at least 140/90 should be your goal. And you have to bring down the blood pressure of that person, of an adult, less than 140/90. And if you cannot control or you are not able to bring down that blood pressure with 3 antihypertensive agents, and one of the agents, if it is a diuretic, especially thiazide type diuretic, then that patient will be labeled as a resistant hypertensive patient. So suppose a patient comes to you with a blood pressure of say 200 by 100, very high blood pressure. So you are surprised at how the patient has come to you by walking, and then you have given him the medicines. Most commonly you will prescribe with a combination medicine. So say after 1 week again the patient has come and you have again checked the blood pressure and then you have found that his blood pressure has come down to say 170 by 94, like that. Then again you will add another medicine, and one of the medicines that you have prescribed is say chlorthalidone, other than say a calcium channel blocker or AC inhibitor. Now again after 1 month you have asked him to come, and please remember that you have to ask him to do all the lifestyle modifications which we will discuss later on. And in spite of doing the lifestyle modifications, in spite of taking all these medicines at the highest possible maximal dose, and one of them is a thiazide like diuretic, and after say 1 month the patient comes to you again and still say his blood pressure is 150 by 94. That means with 3 medicines, one of them is a diuretic, and you have given the maximum tolerable dose, the patient's blood pressure has not come down. So that patient will be now termed as a resistant hypertension. That means the patient is resistant to the medicines that you have given. You have given already 3 medicines, and still the patient's blood pressure is quite high. So you will now treat him as a resistant hypertensive patient. So the ZNC7 defined that failure to achieve goal BP 140 by 90 millimeter of mercury for overall population and 130 by 80 millimeter mercury for those with diabetes or chronic kidney disease when a patient adheres to maximum tolerated doses of 3 antihypertensive drugs, including a diuretic. And if you look at the incidence, then it ranges from 10% to 35%. So the number is not less. Let me remind you that. And this is a study where they wanted to see the prevalence of resistant hypertension, and it was around 12.8% of all hypertensive individuals and 15.3% of those taking medications. So it was done in 2013, and 7.9 were uncontrolled while taking more than 3 medications. So this is quite a significant study by Mayo Clinic. Now, from this study, you can see how the blood pressure is controlled. You see, in this study, in fact, the blood pressure was not controlled in 20% of patients. Blood pressure was not controlled even with 4 medications. So, like you can find similar kind of patients. Now, what will you do in those patients? So that is what we will be discussing today. Now, what is uncontrolled blood pressure, or what is resistant hypertension? You see, sometimes this uncontrolled blood pressure or very high blood pressure, it may not be a true resistant hypertension. It may be an apparent resistant hypertension. Why it is apparent resistant hypertension or pseudo resistance? It may be because of poor BP technique. You may not be examining the BP properly with all the protocols. So maybe it may give rise to high BP, like resistant hypertension. Poor adherence. Poor adherence is very, very common. The patient might not be taking the medicines as prescribed by you. So he might be omitting some medicines, or he might not be taking at the doses that you have prescribed. So poor adherence is very, very common in our country, and in our day-to-day practice, we have seen that it is very common. Even in a country like America, the adherence is less, like only 35% is the adherence rate. So in a poor country like India, you can easily imagine what will be the percentage of adherence to blood pressure medications. Now, number 3 is white coat effect. We all know what is white coat effect. It's a pseudo increase in blood pressure because the patient is anxious, because he has come to your chamber, your clinic, and because of the white coat, or because he's anxious, he's nervous, his blood pressure, his sympathetic tone is now at its full glory. So there will be high blood pressure, which is actually not a true picture of his blood pressure, but because of this sudden surge in adrenalines and sudden surge in other hormones, his blood pressure is high because he's nervous, he's with a doctor or a nurse. So that is known as white coat effect. Now there will be definitely there are some people who will be true resistant hypertension. So in those patients, in spite of giving 3 medications, one of them diuretics, the patient's BP will be high, and those are the patients you are actually looking for to treat. So if you look at pseudo-resistant hypertension, white coat hypertension, the prevalence rate is 22%. Non-adherence, already I have told you it's a big problem. It is 29%, but in India probably it is much bigger, the number is. And true resistant is 49%. So it is not that true resistant population is less, it is still 49%. And so these are some of the profile of pseudo-resistant hypertension. In this Spanish study, this ABPM, this ambulatory blood pressure monitoring, in 2009 it was done, and they have found 14.8%. So in Spain, it is 14.8%. Now, if you look at the persistence of white coat resistant hypertension, then you see the number will definitely come down. If you have seen, say, 29 patients out of 100 patients who have got baseline resistant hypertension, but if you look at them after 3 months, after 1 year, after 1.5 years, you will be able to see that there has been a gradual decrease in this resistant hypertension. The patients who were initially suffering from white coat resistant hypertension. Now, resistant hypertension, assessment of adherence by toxicological urine analysis. So this was a very good study. They did not believe the patient on their on their thing, and they tried to evaluate the urine, and they tried to find the residues of the medicines which they were taking. So if there is no residue in the urine, that means the patient was not taking the medicine. So they were 100% sure whether the patient was taking the medicine or not. So they were sure about the adherence part. So 375 patients referred for uncontrolled hypertension on 3 drugs. So out of 375 patients, they were on maximum doses, and they excluded the white coat numbers. So 108 were actually uncontrolled, and out of 108, 15 with secondary hypertension. Secondary hypertension means the hypertension is because of something else. It may be because of a tumor in the adrenal gland, maybe primary hyperaldosteronism, maybe some other causes. And 17 were controlled on 4 drugs. Now 76 remained uncontrolled, and out of 76, 40 were non-adherent. So that means 30% taking no medicines, and 85% less than half medicine. So you see, your patient may be very nice to you. He may be telling you that he is taking all the medicines, but in this study, 85% of the patients, they actually omitted half of the medicines. So, and 30% of the patients, they didn't even take the medicines. This is a very common problem in our area also. Most of the patients, they don't take the medicines, and they tell you that, or they know when the blood pressure is high. They feel unwell, and it depends on the weather. If it's weather is little rainy and all, they feel that, oh, today I'm going to have problems with my blood pressure, so I should take the medicine today morning. So that is very common. They do not take the medicine regularly. Non-adherence is very, very common. So 36 were actually true resistant hypertension, 3.5% of the referred patients. So you see, there are so many other factors which actually can give rise to a false resistant hypertension. So like the patient may not be taking the medicines, the patient may be taking half of the medicines, the patient may be suffering from other kind of diseases. That's why the blood pressure is uncontrolled. The patient may be suffering from, say, bilateral renal artery stenosis, which will give rise to high renin and leading to high blood pressure. Now this picture shows prevalence of optimal treatment regimen in patients with apparent treatment-resistant hypertension based on office blood pressure in a community-based practice network. And they have found that Out of the uncontrolled hypertensive patients with more than 3 medicines, 31% were controlled, and with optimal treatment, 15% is the control rate. So it's quite good actually. Now, if you look at all these big studies, we all know about LHAT studies, EScort and Accomplish studies. Now, if we go and look back at the resistant hypertension patients in those outcome trials, then in LHAT, 27% of the participants were on 3 or more medications at study end. And 50% of the participants needed 3 or more blood pressure medications. So you see in LHAT, almost 50% patients were kind of resistant hypertension. And in EScort trial, 49% of all subjects were diagnosed with resistant hypertension during median follow-up of 5 years, almost 4.8 years. And then 34% of the previously untreated subjects were diagnosed with resistant hypertension during median follow-up of 5.3 years. Similarly, in Accomplish study, 25 to 28% of all participants remained uncontrolled after a mean follow-up of 3 years. That means these were the percentages of resistant hypertensive groups. So now if you look at the risk factors of having resistant hypertension, this is a study which was done in California, and the same study that I mentioned before in the Mayo Clinic proceedings. And they have found that these are the risk factors. CKD can give rise to resistant hypertension, black race, diabetes, obesity, coronary artery disease, and then cardiovascular diseases like stroke and all, older age group, and male population. So these are some of the risk factors which can give rise to resistant hypertension. And if you look at this, diabetes, obesity, CKD is also a big thing, and other diseases. Now, if you look at the prevalence of primary aldosteronism, you all know that primary aldosteronism can give rise to very high pressure, and the patient may be suffering from this primary aldosteronism actually. So always you have to investigate these patients, these resistant hypertensive patients, for primary aldosteronism, because the percentage rate is almost around, hovering around 20%. You see in Seattle study it was 20%, in Birmingham study it was 22%, in Prague study, Oslo study, it was 19%. So 17 to 22% is actually are suffering from primary aldosteronism in the resistant hypertensive group. So always whenever you define a patient as a resistant hypertension, you have to investigate the patient for primary aldosteronism, because out of those 100 patients, maybe 20 patients will be suffering from primary aldosteronism. So 24-hour urinary aldosterone level and BMI in patients with resistant hypertension. If you look at this graph, these bar diagrams, then you can see that the prevalence rate and the quartiles of BMI. If you look at the BMI and the 24-hour aldosterone level in micrograms, you can see the levels here. So more BMI, that means more 24-hour urinary aldosteronism. Now, percentage suppressed PRA, high APR, ARR, and high aldosteronism in resistant hypertension versus control. So you see in these patients, if you look at the resistant group and the control group, then PRA level is less than 1, ARR level more than 20, and hyperaldosteronism. So you can very nicely see in the resistant group the increased numbers. Now BNP and ANP levels in patients with resistant hypertension versus control subjects. You see in the yellow tower is the resistant group. So in all these patients, the BNP ANP level will be raised if you compare with the control subjects. So you can estimate the BNP ANP levels also in these patients to have an idea about the aldosterone level. So similarly, in this study in 2008, Gaddam et al. Study, it was published in Archives of Internal Medicine. So look at the yellow bar, they depict the high aldosterone level in comparison to normal aldosterone in controls. So BNP and NP levels will be high, and if you compare with the controls. Now, what are the potential mechanisms of refractory fluid retention in patients with resistant hypertension? So number one is obviously hyperaldosteronism. Obesity is one of the major causes where the patient will be accumulating fluid. African American race is seen in America. Chronic kidney disease, already I have mentioned, this can also give rise to refractory fluid retention and high dietary salt intake. Salt intake, if more than 6 grams, can also lead to this kind of high fluid retention in patients with uh, resistant hypertension. And if you look at the blood pressure response to spironolactone, now coming to one of the most important points. Now, all these patients already they are taking 3 medicines, and one of them is a diuretic. Now, what is the fourth medicine that you want to add? So, I think spironolactone is one of the medicines which you can use because it's a wonderful molecule and it decreases the blood pressure quite satisfactorily. I'll talk more about that in my next slides. And in resistant hypertensions, the fourth medicine most preferably is spironolactone. So at 6 weeks, if you look at the blood pressure response in millimeter, it decreased 21 millimeter. At 3 months, it remained 23. At 6 months, it remained 25. So it is quite good actually. So if you look at all this thing and systolic and diastolic variability. Now, if you look at the BP response to spironolactone in PA and non-PA subjects, PA means primary aldosteronism and non-primary aldosteronism subjects. So if you look at 6 weeks, 3 months and 6 months, so it has shown a very nice decrease in blood pressure in these patients, even in PA and non-PA patients. If you look at this diagram in the bars, more response is seen in case of primary aldosteronism and very nice decrease in blood pressures in both the groups. Now, BP response with spironolactone 25 to 50 milligram was found in EScort results. So EScort was a big trial, and you see 25 to 50 millimeter of mercury decrease is quite significant. So if you look at this picture, pre and post, the greenish one is pre, say from 156 of systolic blood pressure, it came down to 135. So this is quite good actually. So minus 21.9, which is quite significant. And in case of diastolic blood pressure, from 85.3, it came down to 75.8, which is quite significant. Now, if you look at this study, spironolactone versus placebo, bisoprolol is a beta blocker, and doxazocin, to determine the optimal treatment for drug-resistant hypertension. This is the pathway 2 trial. And if you look at this picture, you see highest reduction was in the spironolactone group. So placebo, the spironolactone 25 to 50 millimeter of mercury reduction. Doxazocin 4 to 8 millimeter of mercury milligram, 4 to 8 milligrams, sorry. And bisoprolol 5 to 10 milligram. So all these patients, if you look at this, then the reduction in blood pressure, the spironolactone is almost similar to bisoprolol, and doxazocin is also showing some good results there. But there is no effect of placebo. So this picture also shows the reduction of spironolactone. If you look at this red line, then you see it's very linear. It is very predictable, very linear, very optimal. So it's a wonderful molecule if you compare with other molecules like doxazocin and bisoprolol. So this study showed that the blood pressure reduction was minus 3.86, doxazocin minus 0.88, bisoprolol 1.49, a placebo has got 0.68. So if you look at the p-value, only spironolactone had got p-value less than 0.0001. So this is very significant. So spironolactone showed excellent benefits, excellent reduction in blood pressure. So this is a very important slide. So what are the 5 preferable drugs in the treatment of resistant hypertension? considering data from pathway 2, that what I have already showed you, and rehot trials. And particularities including comorbidities and previous side effects may change the order or additional options for other non-coated classes in this table. So now the top 3 classes, we all know that thiazide diuretics, AC inhibitors, or if intolerated, then ARBs and calcium channel blockers. These 3 are mainstay of control of blood pressure. You have to choose amongst these 3 in the beginning. You may give 2 medicines, you may add another one later on. And the 4th preferable medicine is definitely spironolactone. If you look at these 2 trials, pathway 2 and rehot trials, and the 5th preferable drug is actually clonidine at moderate doses. So clonidine is still used, and so these are the data which came out of these 2 trials, pathway and rehot. Now I'm not going to discuss this slide, and I'll just tell you what is actually changed from JNC 8 to this latest guidelines by American Heart Association. Now, first thing first, if you get a resistant hypertensive patient, you have to exclude other causes of hypertension, including secondary causes like white coat effect and other, because it may be because of some medications also sometimes, and then whether the patient is adherent or not. So non-adherence also you have to exclude. You have to exclude any other medications. You have to exclude white coat effect, and you have to exclude any secondary causes like Primaryaldosteronism or some tumor in the adrenal gland or renal artery stenosis. All these secondary causes of hypertension you have to exclude. Now, lifestyle modifications are very much important. You have to, that is the first step actually. So you have to ensure low sodium diet, less than 2,400 milligram per day. So you will control the salt. Now maximize lifestyle interventions like more than 6 hours of uninterrupted sleep, overall dietary pattern, so less sodium, high potassium diet, weight loss. So if the patient is obese, you have to ask the patient to lose some weight. Regular exercise can also help in bringing down the blood pressure. Now, definitely this is a case of resistant hypertension. So you will definitely prescribe some medicines. Now, suppose you have already prescribed 3 medications. Now you will optimize the doses, whether the doses are at the optimum level or not, that you will ensure. And you have to ensure adherence to 3 antihypertensive agents of different classes. So you can give ARB or AC inhibitors, CCB, calcium channel blocker, or diuretic at maximum or maximally tolerated doses. Diuretic type must be appropriate for kidney function. So you will give either indapamide or chlorthalidone, and you will take into consideration the kidney function. Now you have done all these things. You have excluded all the other causes of secondary hypertension. Then you have already done the lifestyle modifications or interventions. You have optimized the 3 drugs, but still the patient's BP is high. It is not at target. The second step will be to substitute optimally dosed thiazide-like diuretic, that is chlorthalidone or indapamide, for this prior diuretic. So you will definitely change the diuretic, and you will add either chlorthalidone or indapamide. Now, BP not at target again. So number 3 step is add mineralocorticoid receptor antagonist. So MRA, that is the step 3. This is the most important point which we are discussing today, because most of the patients we will which we will term as resistant hypertension, those patients we will intervention at step 3, because already the patient is getting 3 medications. You have optimized, no result. You have changed to thiazide-like diuretic like chlorthalidone and indapamide, and then MRA, this spironolactone or eplerenone. So spironolactone is cheaper, it is easily available, so you will add spironolactone to all these patients. Now, in spite of this, if the patient's BP is not controlled, then we will come step 4. So step 4, you will check the heart rate. If it is less than 70 beats, uh, then you'll do something else. But if it is more than 70 beats per minute, you will add a beta blocker. So beta blocker, you can give metoprolol or bisoprolol, or you can also give a alpha beta blocker like labetalol and carvedilol. It depends on other conditions of the heart also, but definitely you can add a beta blocker. If beta blocker is contraindicated, we say the heart rate is less than 70 beats per minute. So beta blocker will be contraindicated. So you can now add a alpha agonist. So alpha agonist means clonidine. So clonidine you can add, and if these are not tolerated, then consider diltiazem. So diltiazem also you can add at step 4. Suppose after that also the BP is not under control, you will then add hydralazine. Hydralazine 25 milligram 3 times daily and titrate upwards to maximum dose in patients with congestive heart failure with reduced ejection fraction. And hydralazine should be administered on background isosorbide mononitrate 30 milligram daily, maximum dose 90 milligram daily. Now suppose even after that BP is not under control, then step 6, substitute minoxidil, that is 2.5 milligram 2 to 3 times daily for hydralazine and titrate upwards. So you will now omit hydralazine in the step 6 and you will add minoxidil. It's a vasodilator, and if BP still not at target, consider referral to a hypertension expert for some experimental studies. So this is how you will treat patients with resistant hypertension. I'm again repeating and summarizing it. Step 1, definitely lifestyle modification, exclude other causes of hypertension, secondary causes of hypertension, optimize 3 drugs, and then step 2, you substitute with chlorthalidone or indapamide for the diuretics if he was taking any other diuretics. Step 3, the most important step, you can add spironolactone or epinephrine, which is an MRA. Step 4, if blood heart rate is more, then you can add clonidine, which is an alpha agonist. If heart rate is less, more than 70, then you can add a beta blocker. You can add metoprolol, bisoprolol, or even you can add an alpha beta blocker like labetalol or carvedilol. Now, step 5, even if not control, you will add hydralazine, especially if the patient is a congestive heart failure patient. And in step 6, you will omit hydralazine and you will give minoxidil. So this is how you treat the hypertensive resistant patients and according to the American Heart Association guidelines. Now, this study also has shown, and spironolactone was the most effective add-on drug for the treatment of resistant hypertension, and the superiority of spironolactone supports a primary role of sodium retention in this condition. So this REHOT study already I talked about. So this study, 12-week treatment with spironolactone, 12.5 to 50 milligram QD or clonidine in 1,597 patients, and similar BP control during office and 24-hour ambulatory BP monitoring. And spironolactone promoted greater decrease in 24-hour systolic and diastolic BP and diastolic daytime ambulatory BP than clonidine. So it was even better than clonidine. And spironolactone is preferred for the 4-drug therapy. So the 4th drug, you must remember that it is spironolactone. So if you look at some of these studies regarding chlorthalidone 25 milligram versus hydrochlorothiazide 50 milligram, and you can see that chlorthalidone has got a better reduction in the blood pressure. So that's why the second step was to change hydrochlorothiazide with chlorthalidone or indapamide. Same type of studies, same type of results. Now, this is the generalized treatment approach. ACE inhibitor or ARB in combination of long-acting calcium channel blockers like amlodipine, chlorthalidone 12.5 to 25 milligram, Spironolactone is the fourth medicine. Combined alpha beta antagonist, that means beta blockers you can give, or centrally acting agents. You can give doxazosine also. Then vasodilator is the last one, the minoxidil. May require use of loop diuretic to blunt the fluid retention in case of minoxidil. Now, effects of salt reduction. You see 6 grams per day. So the blood pressure actually goes down quite dramatically. So salt reduction should always be done in those resistant hypertensive patients. And here, this low salt diet for 1 week, 6 patients were put on high salt diet for 1 week, wash out for 2 weeks, and 6 patients low salt diet 1 week, and 6 patients high salt diet 1 week. So these are some of the results of that study. So if you look at it, the weight and all, the low salt diet, the weight was less. That means the fluid accumulation was less. BNP level was less. Potassium level was high. PAC, PRA level was also good. And so if you look at it, the results are quite good in the low salt group. So this also shows the reduction in blood pressure, high to low salt ingestion. So in office BP, the reduction was quite significant. Both the daytime and nighttime BP control was also good with low salt ingestion. Now this is effect of CPAP on BP. Many patients, they have this obstructive sleep apnea, and which can give rise to resistant hypertension. So in those patients, CPAP, this continuous positive airway pressure during nighttime, is very, very good, and it can decrease the blood pressure. So in those category of resistant hypertension, because of obstructive sleep apnea, CPAP is one of the major treatments. So you have to add CPAP to your treatment regimen. Same kind of studies and same kind of results were seen. With the CPAP group, the results were better. Now coming to the last point, this renal nerve innervation. So there is a new treatment, and it is thought that if we can denervate the kidneys, if we can destroy the nerves which goes to the kidneys, because they can also give rise to resistant hypertension if there is a narrowing. So denervation of renal arteries are a treatment, and it's a catheter-based treatment, and they give a ray and they destroy the nerves so that there is a decrease in the blood pressure. But these studies are not yet very remarkable, and they are not yet kind of recommended. The US FDA has not yet recommended any of these therapies because the results are not that significant. Although this Simplicity Hypertension 2 trial, they showed some benefits and all, but still they are not that significant. So that's why they are not yet the gold standard. These are still in the experimental phase. Maybe in future some more light will come and we will be knowing it better. So I'm not going into the details of renal denervation thing. They have another Simplicity Hypertension 3 trial. So now if we come to the conclusion, already I have shown you this slide. I'm not going into the details, but this is the slide which you have to remember. You have to ask the patient for sodium restriction, weight loss, exercise, CPAP in case of obstructive sleep apnea, ACE inhibitors or ARBs in combination with amlodipine. It is probably the first choice of medicines. Chlorthalidone is the second choice. You can add the diuretic, or you can add it in the first go itself, no problem. Spironolactone definitely has to be the fourth medicine in case of resistant hypertension. Combined alpha beta antagonists you can prescribe. Centrally acting agents like doxazosine or guanfacine, you can prescribe. Guanfacine is not easily available. And then, or hydralazine you can prescribe. And vasodilator, minoxidil can also be prescribed. So this slide, if you can remember, then you can know how to approach these patients of resistant hypertension. And mind it, at least 10% or 10 to 12% of your patients will be resistant hypertension, and you have to resort to these other medications. Thank you very much. Thank you.
Thank you, Das sir. Thanks a lot for highlighting the important aspect of all the subjects. You have minutely explained almost all the details through your trials, and I'm sure it would be beneficial for all the doctors who have joined us. So now what we'll do is we can take some question and answers. I would request all the viewers who have joined us, all the participants, they can type their questions in Q&A box, and Das sir would be happy to answer them. You can type it below and in the Q&A box.
Right, sir. Hello, sir. I'm Dr. Mangesh.
Yeah,
Uh,
hi.
we have a question from audience that why do spironolactone is underutilized by physicians in India?
Yeah, that is a question you should ask the physicians of India. But I think lack of awareness is one of the things, and because MRAs are still comparatively newer medicines, because if you look at the history of all these medicines, and it was not initially indicated for this kind of patients. So it takes some time for the doctors also to accept a medicine and to know about the benefits of spironolactone and all. So they should be used, and they are kind of my favorites. And I always use them, especially the patients with hypertensive heart failure. They are like my favorite medicines. So I usually go for epinephrine, but epinephrine is little expensive. So spironolactone is as good as epinephrine, and spironolactone has got lot more studies to support this combination with diuretics also. So definitely fourth step is definitely spironolactone. There is no question about that. And I hope in future they will understand the importance of spironolactone, and definitely the users of spironolactone will also go up.
Yeah, very rightly said by you. Dr. Deka is asking about what should be the ideal time interval for stepping
Yeah.
up from step 1 to step 2 and then from step
Yes, yes.
2 to step.
That is a very good question actually. So we should at least give at least 3 weeks to 4 weeks for the effects of the medicines to be there. So not not less than 2 weeks. You don't want to change anything. So at least for 2 weeks you have to give the medicines so that the optimum effect is there. And only after say maximum you can wait for 4 weeks. So maybe you ask the patient to come after 1 month or so. You check him again and all, and then you step up your medicines and all. So that is my recommendation. That is what I follow with my
Right.
patients.
Uh,
Want to add something, Dr. Mangesh?
no, sir. Very rightly said by you. One question is there, which is anonymous attendees. There has been a lot of talk on aldosterone breakthrough. Means he says that when patient takes AC inhibitors and ARBs,
Yeah.
the patient after 6 months they would have very high level of aldosterone in their blood. So is it practical to initiate spironolactone in initial stage, or still we have to wait for fourth
No,
line?
no, no, no.
I think
I don't agree. Yes, I don't agree because the current guidelines they have said, both the European Society of Cardiology as well as the American Heart Association, they have repeatedly said the first medications are these four medications only: AC inhibitor, ARBs, diuretics, these three are calcium channel blockers. These four medicines, you can pick and choose any of these medicines. And nowadays, European Society of Cardiology, they recommend that you start in a combination way. You do not start single medicine. You start two medicines, maybe in smaller doses, because that gives the most benefits to the patients. So even if the patient is already more than 140/90, you can directly add a combination of two medicines, like say ACE inhibitors with calcium channel blocker or ARBs with calcium channel blockers, or ACE inhibitors with diuretic, ACE inhibitors with ARBs with diuretic. So you can add at least two medicines. That is what I practice. Any hypertensive patients, I always add two medicines in the first go, and then definitely you have to give the third one if the blood pressure is not controlled, and I will reserve spironolactone as the fourth medication only. So I won't like to start it in the very first go, because that is not what the guideline says.
Right. I think one should follow the guidelines, and by both the guidelines, it is recommended as fourth line, and even pathway rehot
Yeah.
studies have substantiated its use as a fourth line.
Yeah.
So very good answer, sir.
It was a very beautiful study actually, and it was done only for those resistant hypertensive patients, and they studied the optimal medication in that study. So they have recommended that spironolactone is the fourth group of medicines which you should add. So I think we should follow the guidelines. Both American Heart Association as well as the recent European Society of Cardiology, they recommend spironolactone or MRAs only later on, not in the very beginning. So stick to these guidelines.
Right. One question is that what's the role of metoprolol in this resistant hypertension, as well as how does metoprolol would help heart failure patient? There are two questions, I think, in one question.
Yeah, you see, for a normal patient, like without any comorbid conditions, I won't prescribe metoprolol at all. Like in the very beginning, I won't add. Uh, I will add it only after say after spironolactone. Okay, after spironolactone, still if the patient's BP is quite high, the patient is a kind of a younger age group patients where the sympathetic overstimulation is always there. So maybe in those patients, I will prefer metoprolol maybe as the fifth medicine. But the scenario completely changes if the patient is a patient with heart failure, or patient is having some heart diseases like coronary artery disease or so. In those patients, my first preference will be beta blocker. So I will have to prescribe beta blocker along with the other medicines. In fact, I will prescribe the beta blocker in the first go, step one. Like step one is definitely lifestyle modifications and others. So so in those three medications, one medications will be beta blocker, and I'll never omit that. So my first preference, even to control blood pressure, will be beta blocker. Even with beta blocker, the blood pressure is not controlled, then maybe I'll add ACE inhibitor. In those patients, ACE inhibitors are also very, very important, because most of those patients who are suffering from coronary artery disease are actually heart failure patients. So in heart failure patients, you really have to give ACE inhibitors or ARBs. More evidence for ACE inhibitors. So ACE inhibitors like ramipril are preferred. So my first choice will be a beta blocker along with an ACE inhibitor. So that combination I will prefer for controlling the blood pressure if the patient has got a coronary artery disease, or the patient is suffering from say HFrEF, that is heart failure with reduced ejection fraction. So the scenario completely changes if the patient has got other comorbid heart conditions or heart failure. But in a normal patient without any heart failure, without any cardiac problems, beta blocker will come much later on, maybe after spironolactone, not before spironolactone.
Right. Um, Chlorthalidone is making a lot of news because of its high half-life. What's your practical experience of chlorthalidone amongst its peer hydrochlorothiazide and others?
Yeah, yeah. Chlorthalidone is very, very potent. Okay, it's a very old medicine, but recently again it has come into the limelight, and it is very good for those resistant hypertensive patients. I think once I start them on say ARBs, definitely I will prefer a chlorthalidone. Okay, and I'm very fond of chlorthalidone because they can easily control the blood pressure in the so-called very high blood pressure groups. Those resistant groups, they respond very nicely with chlorthalidone. Even 6.25, they do wonders. Okay, like say you are giving him an ARB, say telmisartan or olmesartan, and you add chlorthalidone, then they work wonders. Like the blood pressure will be under control. You can go up on chlorthalidone also to 12.5, but for our Indian patients I am little skeptical because of the side effects and all. So maybe I will add a third medicine with that combination. A calcium channel blocker will be my choice as the third medicines. But chlorthalidone I will prefer even in the first go along with an AC inhibitors or ARBs, depending on the patient's other comorbid conditions. So that is how I would like to add as a first agent along with an ARB or AC inhibitors.
What are the key reasons why patients do become resistant hypertensive?
Yeah, I have mentioned in the presentation that most of these resistant hypertensive patients are actually pseudo hyper resistant patients. Okay, uh, if you look at them, then most of them they do not take the medicines. They take the medicines very irregularly. They take half of the medicines. If you are prescribing two medications, they will probably take only one medication. I have seen it almost every day. So those are the factors. And white coat effect is also there. Uh, so all these things, this adherence, non-adherence is one of the major problems for this kind of patients. The pseudo-resistance, you have to rule out that the patient is not actually suffering from pseudo-resistance. In that study, I have shown you how only 3.8% patients were actually true resistant. And true resistance comes because of various factors, and you have to rule out the secondary causes also when you try to find out a resistant hypertensive patient. You have to, because almost 20% of those patients suffering from resistant hypertension, they actually have primary aldosteronism or some other causes. So you have to rule out those secondary causes of hypertension because those can also give rise to this resistant hypertension. So the numbers are big, but most of the times they are pseudo-resistant. So you have to exclude those. You have to exclude the secondary causes, and then you will find those real or true hypertensive patients who are resistant, and then you can treat them.
Right. Uh, so if patient is resistant hypertensive patient, so four drug combination like AC or ARB, CCBs, and one diuretic, and then we are adding spironolactone. So what
Yes.
are the tolerability issues in long run,
Yeah. Yeah.
especially for spironolactone too?
Yeah. I'll tell you something. You see, whenever you treat a hypertensive patient, so you are preventing certain diseases. Okay, it's a kind of a preventive kind of a treatment. That's why it is very difficult to make the patient understood that these medicines are important, because we all know that hypertension doesn't have got any symptoms. There are hardly any symptoms. Even if the blood pressure is 200 by 100, the patient is coming to your OPD like climbing, like 2 flights of staircases and all. See, he is completely comfortable, no symptoms. He will complain of only very vague symptoms like some pulling in the neck or occipital headache. Sometimes like once in a while or so. So all these symptoms are very minimal, very vague. That's why we call it as a silent killer. Hypertension is a silent killer because it kills the patient silently. Like, the heart changes will be there, the left ventricular hypertrophy will be there, the concentric left ventricular hypertrophy will be there. There will be hypertensive congestion, the congestive heart failure will be there. There will be sudden stroke, and it can lead to death also. It can be deadly. It can paralyze a patient. It can damage your eyes. It can damage the peripheral vascular system, the nerves, and everything. So all these things happen very silently and all. And so that these things they don't happen, you prescribe medicine. So this you have to understand. The patient has to understand that you are giving medicines only reason that you want to prevent all these bad things like heart failure, the stroke, and all other bad stuff. So that thing is really important, and you have to consider. You have to counsel the patient when you prescribe some medicines like for hypertension. You have to tell them that you don't stop these medicines at all. If you want to change something, then you come to me. If you suffer from any of the side effects, you come to me. And remember, you are adding the fourth medicine, or you are giving fourth medicines because the blood pressure is not being controlled with three medication. You see, it doesn't matter how many medicines you have given. The only thing matters is that the blood pressure has to be controlled. So that is our goal. It has to come down below 130/80. So now uh, you will add on medicines, the maximum tolerable doses, and so whenever we prescribe a medicine, we always weigh the risk and the benefits. So we all know that the risks are better if we control the blood pressure. So, the benefits are better if we control the blood pressure. So it doesn't matter whether you have given 4 medicines, 5 medicines. Till that time, there are no major side effects. You continue all these medicines. You do not stop any of these medicines. At least till the time the patient's blood pressure is controlled, at least for 3 months. Then maybe you can come down on the doses, and if you are lucky, then you may be able to stop some of the medicines also in
Right.
some patients. Yeah.
Avinash, over to
Yes,
you.
sir.
Thank you.
Thank you, Das, sir, for taking all the questions. Sir, any concluding remark on this subject from your side?
No, I'm very happy and with the participants and all. In these days and all this bombardment of webinars and all, 25 people joined. I think 5 of them are from your side, and at least 20 doctors they joined to know what is happening to resistant hypertension. So it's a very good thing, and I congratulate you for organizing this CME webinar very nicely. Thank you.
Thank you, sir. Thanks a lot. It was our pleasure. Thank you once again, Das, sir, for sharing your valuable time and knowledge with us. It was indeed a pleasure having you here today with us, and we hope that we meet next time again and on some important topic again.
Yeah.
Also,
Thank you.
thanks to all the viewers who have joined us. Till next time we meet, on behalf of RPG Life Sciences and complete team of RPG Life Sciences, take care, stay safe, and goodbye. Thank you.
Thank you. Bye.
Thank you. Good night.
Good night, sir.